The golden hour, the critical minutes after heart or brain injury. Hello and welcome to the channel. I had cause to reflect on a crucial theme in medicine the other week, a somber moment that reminds me of the necessity of outreach of medical education. I was out and about and came across a sight that made my heart sing. There in front of me was a giant bouncy castle in the form of a big red helicopter with the words Rega printed on it. The Rega, R-E-G-A, is the Swiss Air Rescue Service. It is basically the equivalent of the search and rescue service that Prince William of Great Britain served in Norfolk. The name Rega comes from an amalgamation of the German and French versions of the name of the service. So in German, Rettungsflugwacht, and in French, Garde Aérienne. If you take the first two letters of each, you have Re from Rettungsflugwacht and Ga from Garde Aérienne. There were children jumping on the inflatable slide leading out of the helicopter. Nearby were ambulances, lifeboats, and fire engines, and the respective staff of these services were there to answer questions from the general public and show them what their respective professions was all about. It was clearly an education day all about emergency services, whether by land, sea, or air. It seemed to me to be children-focused, hence the bouncy castle. There are clearly some big kids out there, because the people bouncing about were not all actual children. There were demonstrations of CPR training, cardiopulmonary resuscitation training, with mannequins playing the part of someone collapsed and near death. Adults and children were being desensitized from the deer in the headlights stage fright that I can imagine can take hold of you if someone collapses in front of you suddenly and you have no idea what to do. I say I can imagine because, of course, this kind of stage fright is no longer my reality, and honestly, maybe never really was. I was always drawn to medical emergencies as far back as I can remember. Never one to fear the sight of blood. Whenever there was a medical emergency, you would find me. It was my thing. I was drawn to it. It seemed to follow me wherever I went. At airports, in planes at high altitude, in sports complexes, hospital car parks, even on remote mountains in Europe. For years, the emergency room was my home. And later, I found myself honing in on heart emergencies. I mentioned in a previous video that I worked in emergency medicine in 2 coastal areas in the UK, where I got to experience firsthand about the amazing work of the RNLI, the Royal National Lifeboat Institution. I take my hat off to them, incredibly dedicated and brave folk. These days, my working life is a bit more tranquil, but still, I am not ever far from a heart emergency or two. Without giving away too many identifying details, on a normal working day in my practice, I went to the waiting room as usual in search of my next patient. This was a man who was never, usually, late. I was a little surprised not to see him there, but then I thought nothing of it. It happens. People miss appointments all the time. I called up the next patient, who, in our pre-consultation small talk, made the odd remark that on her way to my practice, she had been distracted by an incident nearby where an ambulance had arrived to aid a patient who had been found collapsed by a bystander. I had in fact also heard an ambulance siren a few minutes before, but had thought nothing of it. I only put two and two together and connected the dots when the consultation was interrupted a few minutes later by an urgent call from the heart specialists from my local hospital, who informed me that my absent patient was on the table in the heart operating room, what we call a heart catheter lab, undergoing an emergency coronary angiogram, and they needed vital information from me about his medical history. My patient had been on his way to his scheduled appointment with me when he suddenly collapsed in the street just 5 minutes away from the practice. The good news is, I'm very happy to report, he's alive and well with minimal downtime recorded during the incident. What do I mean by the term downtime? This is the time when a person is unconscious. Heart has stopped. There is no brain activity. They are on their way out. Unless someone stops that journey. And someone did just that. A quick thinking passerby started CPR, called an ambulance, and got my patient the help he needed fast. He is only alive today because of that person. A heart attack, medically known as a myocardial infarction, is a life-threatening event that occurs when the blood flow to a part of the heart is blocked, usually by a blood clot, leading to the death of heart muscle. The moments following the onset of a heart attack are crucial for the patient's survival and recovery. Among these moments, the first hour, commonly referred to as the golden hour, is especially critical. During this period, prompt medical intervention can significantly influence outcomes, including survival rates, the extent of heart damage, and long-term quality of life. To understand why the golden hour is so crucial, it is essential to grasp the physiological changes that occur during a heart attack. Here comes the science part. A heart attack typically happens when one or more of the coronary arteries supplying blood to the heart muscle becomes occluded. This blockage is most often due to atherosclerosis, a condition where plaques made up of fat, cholesterol, and other substances build up in the arteries. If a plaque ruptures, a blood clot can form, further obstructing the flow of blood. When the heart muscle is deprived of oxygen, and therefore oxygen-rich blood, the affected area begins to suffer from ischemia, basically oxygen deprivation, and if untreated, starts to die. Within the first few minutes of the heart attack, the body attempts to compensate for the lack of oxygen by increasing the heart rate and contracting blood vessels to maintain blood flow to vital organs, like the brain. However, if the blockage is not quickly resolved, the ischemic damage becomes irreversible, leading to necrosis, tissue death of the heart muscle. The extent of this damage is directly proportional to the time elapsed since the onset of the blockage, hence the critical nature of the golden hour. The golden hour is crucial because it represents the period during which the heart muscle is still salvageable. The faster a blocked coronary artery can be opened, the more heart muscle can be saved. This is why we have the expression, time is muscle, in the context of a heart attack, a play on the adage, time is money in the financial world. Multitudes of research into outcomes in emergency situations have shown that if a certain chain of survival is fulfilled, the chances of survival of the victim are greatly increased. This chain of survival can be found in any basic or advanced life support manual and is the bread and butter of any emergency response health provider. This chain of survival has these components: early access, early CPR, early defibrillation, and early advanced life support. Let's tackle these one by one. Early access. Recognizing that a cardiac arrest is happening is the first step. And this is exactly why I mentioned earlier on in this video that seeing the general public education going on with the inflatable helicopter to educate even children made my heart sing, because it takes the fear away from being confronted with such a scary situation, especially if it involves someone you know. The person that helped my patient knew instantly what to do. They had received some sort of training. It worked for my patient. Early CPR. If someone starts chest compressions, the moment it is confirmed that the victim's heart is no longer beating, we put that person on a ladder of survival. They have a much better chance than if nothing happens. No one is dead until a doctor says they are dead. And as you would have heard in this video here, even that is not a full money-back guarantee. It is exactly this kind of scenario that leads to all kinds of difficulties with establishing end of life. The best advice is to keep going with your resuscitation attempt until a designated qualified person or team make the decision to stop, usually based on a consensus decision. With a ratio of 30 chest compressions to 2 breaths, CPR helps to move blood and oxygen around the body until an automated external defibrillator, AED, arrives on the scene, or help in the shape of a doctor or nurse or emergency support worker, EMT, emergency medical technician, arrives. If there is an issue with giving breaths, the so-called kiss of life, because of hygiene reasons, don't worry. Doing just the chest compressions alone will be just as useful. Early defibrillation. Apply electricity to the heart. Have you noticed that everywhere you go, you will find an AED device? This thing here. In shopping malls, in schools, in parks, at airports, in town halls, everywhere. There is a reason for that. It is to allow access to electricity to restart the heart of anyone whose heart stops beating because the electrical activity has gone haywire. It's like a phone charger point for the heart. Early advanced life support. Even if on the street you are being resuscitated by a bystander who is himself a world-renowned heart specialist, your outcome may be just the same as when Mr. Joe Public is doing it. Why? Because no matter how much you can help a patient by yourself, a hospital setting with all its equipment, adequately trained personnel, and network of advanced care providers is superior to one person going it alone on the street anytime. The goal is always to get to hospital as fast as possible. Nothing should stand in the way of that. Once the patient is safely in hospital, the well-rehearsed chain of events can smoothly take place, resulting in a good outcome, like it did for my patient. Often the hospital is pre-warned, and an appropriate team is gathered up, ready and waiting for the patient before they even get to the hospital, in what is referred to as the red phone system, or as we like to nickname it, the hot phone. This is a dedicated phone line to a receiving hospital by a dispatching ambulance service when they are en route. For a cardiac arrest or cardiopulmonary arrest situation, either known, so already expected by the ambulance crew before they even get to the call or get to the residence after having received a call from a member of the public, or a situation where a breathing, talking patient suddenly goes under, loses consciousness en route to hospital. Either way, the red phone system is there for the ambulance crew to quickly alert the receiving hospital. Examples of receiving hospital teams that deal with such emergencies are trauma teams. These people are highly trained to deal with multiple pile-up disasters that include collapsed buildings, air crash disasters, multiple vehicle road accidents, sports stadium crowd disasters, and natural disasters or war injury issues. You have cardiac arrest and stroke teams who deal with serious heart and brain injuries that are not caused by external forces. You have obstetric and pediatric arrest teams that deal with severe out-of-hospital emergencies that involve pregnant women who may be laboring or giving birth in unusual and unsafe environments like in a war situation, and babies who are born in such environments, or children who are in an emergency situation following abuse or neglect. So far, we have focused on the heart and the importance of recognizing a heart event happening in front of you. Is someone complaining of sustained chest pain which feels like a pressure without any exertion on their part? Are they sweating profusely or feeling nauseous or even vomiting? If they are female or elderly or diabetic, their symptoms may be completely unexpected or unusual. Are they suddenly a bit confused, breathless or faint? Are they complaining of palpitations, a fast heartbeat? If they are, they may not be very far off from the cardiac arrest that will surely follow. A stroke is not always easy to spot. A quick way is to ask yourself 4 simple questions that spell the word FAST, F-A-S-T. Is their face paralyzed? Is their arm paralyzed? Can they speak? If so, time to call your local ambulance service, FAST. Studies have consistently shown that early intervention significantly reduces mortality rates in heart attack patients. For example, the mortality rate for patients with serious heart attacks, so-called STEMI heart attacks, who receive a stent for a blocked heart artery within 90 minutes of the first medical contact, is significantly lower than for those who do not get a stent in this time period, called the door-to-balloon time. The balloon being referred to here being the mounted balloon on a catheter that is used to expand the blocked artery to open it up, and the door referred to here being the door of the hospital. In most centers of excellence, this door-to-balloon time is well under an hour, some even less than half an hour. Such is the smoothness of the military-style operation to get the patient as fast as possible onto a catheter lab table, the heart intervention table. Similarly, timely fibrinolytic therapy, blood thinning with powerful drugs to thin the blood after a heart attack or stroke, has been associated with a marked reduction in early mortality, particularly when it's administered within the first hour of symptom onset, in what we call pain to needle time. The needle being the vein port through which the thinning medication is administered. Delays in getting the right medical help for a patient can, as you will expect, occur at various levels within the chain of survival. You may have friends and family who may not recognize that grandma is having a heart attack before their very eyes because she has atypical symptoms. You could have a patient who doesn't want to bother anyone and may not even seek help, preferring to see how it goes. I have even sadly witnessed situations where a patient rocks up to the busy emergency room and waits patiently for their turn, whilst patients with simple things get seen first, until they either collapse or a vigilant triage nurse spots them sitting quietly in the corner, not looking very well. I recently had a patient wait 3 days before dragging herself to come see me in my practice, preferring not to go to hospital. By that time, she had started going into heart failure. Even so, she still refused to be hospitalized, discharging herself a few hours later to go home to die. Death from untreated heart attacks are frightening to watch and incredibly scary to experience. All kinds of mayhem may ensue, including actual rupture of part of the heart muscle, causing a valve, usually the mitral valve, between the left atrium and the left ventricle to leak badly.
Upper left heart chamber, left atrium, and the lower left heart chamber, left ventricle. A healthy mitral valve keeps your blood moving in the right direction. A leaky valve doesn't close the way it should.
You can have a bulging out of the pointy part of the heart called the apex, causing what is known as an apical aneurysm. And the heart rhythm of the heart can completely get out of control, resulting in the immediately life-threatening heart rhythm known as ventricular fibrillation, or VF. And it is this heart rhythm that we need a defibrillator for. There are also issues with location. If you live out in the sticks in any country, your access to tertiary medical care may be limited, especially in bad weather. But in some countries, this inequality in care is minimized to such levels where it is negligible, like in Switzerland. The golden hour after a heart attack or stroke represents a critical window of opportunity where timely medical intervention can save lives, minimize heart damage, and improve long-term outcomes. It is a race against time to prevent permanent damage to these essential organs. Have you been up against the clock in the golden hour? Or has a relative or friend of yours been there? Can you remember the experience, or was it traumatic for you? Did you feel like you were in good hands with calm, efficient medical personnel taking care of you? Tell all, if you can, to Askadoc.